Welcome to the next episode of Mic'd Up with Chiro Up. You've got Tim and Brandon today. This is going to be a very good episode where every episode merges opinions with a little bit of research, and then we kind of blend them both in together for real life scenarios that every chiropractor is living. Today is going to be a really good episode with Dr. Burlesman in the studio to moderate. Very excited to have him here on board.
Yeah, thanks for inviting me back. That might be a strong term, the invite. I kind of had to hack your computer to find out when you record these things.
I purposely leave these things off in my calendar, so sometimes I get to just speak into the mic, but that's always fun. Just as a reminder, if you haven't yet hit the follow button, share this episode with a friend. It really does help us reach more people. It's always fun to get more DCs listening to the episode, but also what I noticed from this last episode is we have DCs who are really giving us a lot of feedback. And the feedback that I got on the last episode, which was about heel pain, was why did you leave out the Achilles tendon? So I thought, why not? Let's address it in this one. Before we dive into the clinical aspect of this podcast, we want to cover a couple things. First, I really want to go through the most pressing issue, which is obviously I need to change my password. I don't know how you got in my computer and how you figured out I was recording this podcast today, but we are actually going to talk a little bit about security and compliance and how that factors into our workflow at ChiroUp and Premier Rehab. We'll cover that at the very end, which will be, some people look at that as the boring stuff. However, some cool little things that we do in our practice and our business that I think will help each and every one of the listeners. I think that the next piece is once we get done with the security compliance piece, is I want to talk about a couple studies because very often chiropractors and scoliosis are almost synonymous. Everybody thinks we treat scoliosis, and sometimes I feel like I'm not doing enough because I really don't see that many scoliosis patients, and that's not that I can't treat them. I just don't actually get them in my office. So yes, we're going to cover some cool studies in scoliosis, things that I can do, some things that you can do, and maybe even Tim can do in his office, and how we can help these people both with acute pain, but also that structural abnormality that can be addressed both in the educational realm, but also in the manual therapy realm. And then we're going to have a fun discussion on heel pain and go through the most common cause of posterior heel pain, and that being the Achilles tendon. And I think that's where the meat and potatoes of this podcast really come in. I did not cover it in the last podcast on purpose, is because this is a big, hairy, smelly diagnosis. This is a huge diagnosis. And I thought it was, the reason I thought of this podcast right after the last one was my marketing team, they're not my marketing team, Tim and I's marketing team, creates the titles to everything we do because they're much better at doing those things. And the title they gave the last one was on how to unravel the mystery of heel pain. And whenever I heard that unravel part, I thought to myself, well, that's actually a really good title for the next podcast.
I knew you didn't create that.
Well, I don't create much of anything. But I think that this unraveling piece is what I want to get into today. And then, where these injuries happen and, how to treat them with the Achilles tendon. And Tim knows that I think puns are the worst form of comedy. However,
It depends on who says it.
when I talk about unraveling, who here understands why that affects the Achilles tendon? And that's what we're going to cover today, is that's one of the most interesting things about this tendon, that in the next 20 minutes, I really want to focus on that because I think that if we can focus on this unraveling piece, it'll give you and I some understanding of how these things happen, but also probably just as important, that why the rehab is so important. And I think that we can kind of combine all those things into one and understand the condition, how we're going to treat it. It really helps us and our patients get through care. And then finally, just like I talked about, is that we're going to end the podcast with a fun exercise led by the man who runs the show here, Mr. Organized, our fearless leader. Tim is going to show you how we use something called the EOS system. And how it has shaped ChiroUp, but also permeates our private practice and our clinic. And I think that's where we can end things out and kind of round out this podcast. Before we get into all those things, let's really go into the research review. We like to start every podcast with some research. And Dr. B is going to shed a little bit of light on a couple papers talking about scoliosis.
Scoliosis is a great topic because so few of those cases actually need care beyond what we can offer, that less than 0.5% of scoliosis cases are going to require surgery. And usually those are kids who have a significant curve, and significant would be something above 40 degrees. So the vast majority are possible patients for you and I.
So I mean, if it's not many people and it's not very surgical, I think the thing that kind of goes through my brain when I get a parent walking into my office is, what am I going to do for these, what's going to help them? What's going to help this patient?
Yeah, fortunately, we have lots of help from the literature saying what's most effective, and it's what you and I know would be most effective for those patients. We may not completely correct their curve. In fact, we're at no disillusion that will completely correct their curve, but if we can make them more comfortable in the same way we make our other patients comfortable, we give them exercises, we mobilize them, and in some cases, kids may need a brace as well. There was a study that came out, I think it was in July, from the Journal of Children, and it found that the Scroth exercises were effective at decreasing the Cobb angle as well as the angle of trunk rotation, and this is for adolescent idiopathic scoliosis patients. That means a significant change in their quality of life as well as improve their strength of the lumbar erectors. So it tells us that these things are definitely potent, that our tools work.
This is a little bit off topic already, but that's okay. We're soon in the podcast. One of the most interesting things about that statement you just said was improving patients' quality of life, yet very few of us actually ask those questions. We can talk about pain. We can talk about, where's your pain level and how high can you pick your arm up? But that may be something that is very important to our patients is how much better are you doing after a course of care? One of the things that we did a long time ago, which was the initial creation of the scoliosis condition reference, is we had to make that differentiation between the scientific exercise approach to scoliosis, which is called the SEAS 6, as compared to the Scroth method. And they both have a ton of research. In fact, the Scroth method, I believe, is more widely used. However, in looking at it, when we're looking to stabilize the spine, we're looking to reduce the Cobb angle of scoliosis and decrease pain. Both of them have a ton of research on how to do that. And what we found is that in our condition reference, and I believe there's over 90 references on that specific condition, is that the SEAS method was a little easier to follow with patient compliance. So that's where all of our videos come through as far as how to assess and how to treat scoliosis through the chiro method.
Yeah, the next article that was just published showed that spinal mobilization and stability exercises were certainly helpful for not just the patient's quality of life, but particularly the amount of pain that they're experiencing. Most of our patients come in because they're looking for pain relief. In fact, about a fourth of patients who have scoliosis, idiopathic scoliosis, are there because they have pain. So these patients are looking for something that can make them feel better. And the Journal of Pediatrics and Child Health found that if we add spinal mobilization, things that you and I are experts in, to treatment, we can reduce the magnitude of the curvature and improve scoliosis-related problems in the short term, including the amount of discomfort that those patients have.
And I think there's a touch of psychological component to that when especially an adolescent has pain, they will start to live a smaller and smaller life because they think they're hurting their back or hurting that scoliosis, getting worse. So one, it's good to relieve that pain, but also I think it provides that window of opportunity, allowing the patient or probably showing the patient they can live a pain-free life, and then finding ways, like I said, through the chiro condition reference, we use the autocorrection method, that I think these things can help improve their posture, and now they're able to do more and more things.
Yeah, absolutely. A win for the conservative care. And by conservative, there are all sorts of things that we talk about. It just means non-surgical. But some conservative things are a lot easier for an adolescent to digest than others. That if we think about braces, and there's a lot of controversy about braces, that getting a child, first of all, to wear a scoliosis brace, talking a teenager into wearing this big contraption for a long period of time each day is a challenge. And in some cases, those are necessary. There was a study that came out that said, yeah, they do help. That if we have somebody who's approaching the point that they may need surgery, a brace may be a tool that helps them prevent surgery. In fact, 3 out of 4 cases are prevented from surgery. There's also a study that says the amount of time that those are worn makes a difference, that there's a lot of debate here as far as how long. It might be half a day, it might be 23 hours of the day, but the recent research suggests that the longer that the kid is wearing this brace, the better the outcomes are. And a lot of times we don't need to get to braces, but when we can combine what we're doing with the brace, we may even get better outcomes. If you'd like all the references of the things that we're talking about here, where did this information come from, as well as the patient education, what are these exercises that our patients should be doing, including the rehab videos, you can check those out in the condition reference for scoliosis in the Chiro Up protocol section. So now, Brandon, you kind of got everybody excited here about unraveling the heel. Tell us more about what we're going to learn today.
The foot is just an interesting part of the body that it has to do so many things. So I think that I do get excited when we talk about gait and the feet and the rocker system and the feet, because there's so many things that happen and then compensations to those things. But before we get to that, let's give a couple of the facts that are going to talk about this malady, because I think this is one of those things that we may hear a lot in practice but don't necessarily treat. And what I mean by that is that I have a lot of my patients who, when they lay down, they get a little dizzy, or when they sit back up, they get a little dizzy. Well, that's a symptom. Now, are you ready to treat that? We have patients that come in, they have some heel pain, but I'm already treating their back. What do I do? Do I start treating both of those things? Or, how does that happen? And there's a lot of patients going to come in to see you after that, week long in Disneyland. They come with heel pain, but you're already treating them for headaches. Just out of curiosity, Tim, what are you doing with a patient? You're midway in treating a lumbar spine disc lesion, and they come in with a different problem. What's your method on that? What's that conversation look like?
Like a completely different, like a carpal tunnel syndrome?
Let's call it a heel pain.
They come in with heel pain and they have low back pain. Well, I'd love to make a connection. Like, it's easier for that one, certainly low back pain and heel pain, that if their heel is giving them trouble, they're walking with a different gait, it's going to put different stress. But that conversation is really digging down into what could be the underlying functional deficit that could be leading to both of those. In this case, that patient with heel pain, Achilles tendinopathy, or whatever it may be, is likely contributed to by some hyperpronation of the foot, which certainly is a contributor. So a lot of times it's a reminder to me that when I see a tissue that failed, a disc that failed, or an Achilles tendon that failed, or a rotator cuff tendon that failed, whatever it may be, that's a symptom of something. That glass overflowed, and the stressors in that patient's life exceeded it, so the glass overflowed. If I start to see a couple of things in the same chain, now I'm thinking there may be something that I didn't identify here. And so trying to get the patient to understand you've got multiple issues in the same chain. Let's get to the underlying issue and let's get this stable from the foot upward.
I'm glad you said that, because that's my biggest differentiator also, is that if I believe that secondary complaint is related to what I'm already treating, I'm going to go ahead and co-treat. If I believe they have plantar fasciitis and they just started developing headaches where I can't draw that connection, I do wait until I get that, at least that first one, under control, good progress, everything, they're 75% better, they're rolling on with some rehab before I start treating two things, because otherwise the treatment and the rehab does get kind of intertwined and sometimes confusing for the patient of what they're doing and why they're doing it. But let's get back to the heel. I was just curious on your thought process with that. So the Achilles tendon is really a tendon to its fullest extent. And the reason I say that is because, muscles have tendons, but due to the size of the tendon, it has a very different function. So if you have a muscle with very short tendons, meaning it's mostly muscle, a little small tendon that attaches to the bone, it has very different physiology as compared to a smaller muscle with a big long tendon. So think about this. Think about a muscle like maybe the quadratus femoris, right there on the backside, posterior side of the hip. It's a very strong external rotator and adductor of the thigh, but as you and I know, it's really there to essentially control that torque, or prevent that eccentrically loaded hip in the gait cycle. This muscle is going to limit internal rotation. It's going to limit abduction of the femur when you maybe slip on some ice or when you're running uphill, those kind of things. If you have a weak one, you can create something called ischiofemoral impingement. You'll see that uncompensated Trendelenburg. There's just not much stretching here. It's a torque muscle. It's a strong muscle. However, in the Achilles tendon, this is a very remarkable structure. It has ability to store and return nearly 90% of the energy. So that's what makes us so efficient as far as walking, is that we can use this tendon to stretch, but then recoil, and now the ability to supinate the foot and propel yourself forward.
Yeah, so is that what this unraveling that you keep talking about refers to? That's what I want to know. But before you answer that, A word from our sponsor. You're going to love this company. Take a listen.
Can't get enough of the information you hear on our podcast? You will absolutely love our platform. ChiroUp helps thousands of chiropractors across the globe simplify the way they practice using our online evidence-based software. It's your one-stop shop for powerful clinical research, simplified patient education, and smart practice resources. Visit chiroup.com, try it out for free. And if you'd like to subscribe, use referral code podcast15 for 15% off 12 monthly billing cycles. No contract required. Offer valid on new subscriptions only.
That sounds like a pretty good company. I think I'd use that.
Probably so.
We are so shameless. That's part of the reason we did this podcast. Is one to show a little
To
personality.
show that we're shameless.
Shameless. But really, it's just a way for us to get out and talk to the subscribers that we have out there. So I appreciate you guys for listening and the feedback you get, because that's the only reason we do this. We have nothing else going on Tuesday at 8 in the morning anyway. So unraveling, yes, I do want to cover that, because the first time I saw this, which is kind of a shame to say, that I never even really realized in school, is that the Achilles tendon is not the tendon of the medial gastroc or the lateral gastroc. It's actually a synthesis between medial lateral gastroc and also the soleus. And these individual tendons don't really just turn into one tendon. They're their own individual tendons, and they rotate between 26 and 130 degrees around before attached to calcaneus. And this twist, maybe I guess I can call it, is like a coiled spring. And when it's stretched, it can absorb that shock, which is good, And then the most I guess cool part about this is that it can return 10 times more energy than the neighboring, the gastroc soleus. So it's not just using the muscle; it's using this structure of these type 1 collagen cells to actually absorb that tensile strain, and then also bring it back to the foot. So now that we can run or jump or what have you. If you do want to see a great picture of this, I always like going to Tom Michaud's website, humanlocomotion.com. In the article section, you'll see an article on Achilles tendon. You'll see a ton of articles, but he's got one on the Achilles tendon, and it's got such a good picture. I haven't seen this anywhere else, so somewhere good to look at. But back to unraveling. So like I said, this tendon is not just one tendon. It's actually a synthesis of that medial gastroc, lateral gastroc, and soleus. And this is the cool part, is that based on how those things stretch and how they pull away from each other is something that we can understand. That's how injuries happen, because it's a very tensile area, not very much blood flow. But the second piece is when those tendons stretch upon one of each other, we can actually get better rehab and get that tissue to heal faster. So I think that the thing that always confuses me is that when I have something designed, so well, why do we get injuries? And I think to myself about the hip, described as Manel as the perfect joint, yet it's replacing 2 of every 100 people in the U.S. Why are we getting problems here? And I think just as importantly, when we talk about tendinopathies, we can understand how they happen. But I'd like, Tim, for you to shed just a little bit of light on, one, the tendinopathy argument, but also why do we see so many non-insertional Achilles tendinopathies as compared to insertional?
Yeah, we just see a lot of them, period, that up to 1 million people in the United States have an Achilles tendon injury, not necessarily a rupture, but some sort of a tendinopathy or irritation throughout the year. And that's not surprising that when we run, we're placing 12 times our body weight on that little chunk of tissue. That's pretty intense. And there's 2 places that can go wrong, really 3 places that can go wrong in the whole chain there. And it's whatever the weak link is, whichever glass is closest to being overflowed. As soon as you put another few drips of stress in it, that's the one that's going to give. It can be an insertional Achilles tendinopathy, which means that's right where the tendon inserts, not surprisingly. That's what we call the Haugland deformity, or the pump bump, where you see a little bit of knob on the back of the calcaneus. That's not nearly as common as the non-insertional Achilles tendinopathy, and that's 2 to 6 centimeters upstream. So just a little bit up. There's a few reasons that it happens there more commonly. That number one, it's a little bit thinner. There's less cross-sectional area. Number two is that there's not as much vascular supply. That's a dense tissue that's made to be stretched and pulled, and vessels don't stretch and pull real well, so it's very dense with the fibers, not as much vascularity. And part of the reason for vascularity is what you alluded to earlier, or described earlier, that there's a ringing that takes place, that tendon kind of wraps in that area. And especially when we go from supination to pronation, that Achilles tendon torques a little bit. Think of your beach towel that you dropped in the ocean. Now you grab each end of it and you twist it. That's how blood gets wrung out of it. Very similar to what happens to the rotator cuff when we abduct our arm. So that's the vulnerable point, and that's where things go wrong. And then the last thing where things go wrong is if you have somebody who's young, an adolescent, or a child, the weakest spot in their chain is not the muscle. It's not the tendon. It's where the tendon attaches to the bone as far as that growth plate. So the growth plate is significantly weaker than an Achilles tendon. When you have that kid who's out playing soccer or football or running all day long, if something's going to give, it's going to be the growth plate.
It's so interesting to say that, because unfortunately, if some of those things aren't rehabbed properly, what's going to happen is they're going to start to compensate. They're going to run differently. And what we know by the foot is as soon as they have any kind of a foot pain, they are automatically going to shift all their way to their outside part of their foot on the lateral column with all those bones, because it's more stable than the inside part of their foot with the arch. So you start to see Taylor's bunions. You can see increasing loading to the knees and the hips. So really, we need to get these things fixed as soon as possible, just like every other diagnosis. But really, with the foot, if they don't get that pain to go away quickly, they're going to find or adopt a new posture or movement to get that to go away. So that leads me into the last piece of this about Achilles tendinopathy. I'm not going to go through a lot of the treatments. The treatments, you can do instrument-assisted manipulation, a lot of the same stuff we do for all the different tendons, or soft tissue manipulation, dry needling, what have you. However, let's shed a little bit of light on some research on how to rehab these things, because one thing that I find extremely interesting is when I first started out in practice, I worked with professional athletes, and the things that we did to them, we didn't do to anyone else. And I always thought it was a little bit mean, but the athletes were always the no pain, no gain kind of person. So I just figured that's why we were doing it. But at the end of the conversation, at the end of the internship that I had with that and my supervising provider, is they require a little bit more. So that's what I want to talk about with this, is that when you look at a tendon that's so strong like the Achilles tendon, we have something called the Alperson protocol, where you're going to do some eccentrics training, 3 sets of 15 repetitions with the knees straight and knees bent daily for a long time. I don't think it's even 7 days. I think it's like a month of doing that. And that's what I use for most of my patients. But when I have someone who's a marathon runner, an athlete, it's not enough. And so what we know is through the recent research is that heavy resistance, long duration isometric contractions will also help accelerate tendon repair. And the thing that I like to do with that is that at the very beginning, when they're having still some pain, I am a heavy resistance, long duration isometric hold, essentially the foot on a step, finding the area that hurts and holding it there for a long period of time. What the research is showing is that they should be, that isometric contraction should be anywhere between 30 and 75% of their maximum voluntary contraction, and holding it for a long period of time. As they start to do that, and as they get better at doing that, then I go back into the Alperson protocol and I do 4 sets of 20, and I'll even put some weight on them to load them up there, because what we know is that both of those things are doing the same thing. However, what they're doing is actually taking that tissue of the tendon and just stretching it to its maximum load. And there's some Australian researcher says that it really has to do with fluid flow dynamics, but what is happening is with that internal core of that tendon never really gets stretched if you just use it a little bit. We really want to really load that tissue up, and we're going to give you some exercise you can do within chiro for your patients. And you don't necessarily just want to do that with your knee locked and isolate just the calf muscles. You can do that locked and also knee bent. And what that's going to do is when you have your knee bent, it's going to offload a little bit of the gastroc and put more of the stress on the soleus, and the exact opposite is true with the knee straight. And so that unraveling piece is we can actually isolate which muscles we're pulling at preferentially, along with loading it. And this is an opinion, this isn't necessarily a fact, but I'm not so sure it's really the fluid, fluid being squeezed out from the tendon that's helping that tendon heal. I think it's the crazy amount of force generation, because if you want to stimulate tenocytes the most, what we're seeing in the tendinopathy research is stress it. Now, it's already irritated. It's already painful. You don't want to make it worse. However, finding that pain that's a 3, maybe a 4 out of 10, they're a little bit sore afterward, but not too sore the next day. That's really what we're looking for in this kind of rehab. And I think that if you can do this, you can have that professional conversation with your patient. Say, hey, this is going to hurt a little bit at the very beginning, but the next 4 weeks, we're going to remodel that tissue, get it to start getting stronger and build the capacity of that tissue. Not only can we get these pains to go away, but now we can actually get those pains to go away and, which most people can't do, get it to stay away. So how do we get this to go away? What are the best rehab exercises, Dr. B?
Yeah, lots of data on that one as well. There's, as you talked about, the Alfredson protocol is one that's fairly well established. There is some new Finnish research that said that we need to do those exercises with the knee straight and the knee bent, because we know that the gastroc and the soleus portions of that tendon can be worked differently, that the gastroc is going to be stretched when the knee is straight, and in order to get to the soleus, we got to get the gastroc out of the way, so we have to bend the knee. That the research from Finland said that healthy Achilles tendons exhibit non-uniform intrafascicular sliding because different muscle pulls from the gastroc and soleus. And that different degree of sliding is what really stimulates that tenocyte activity. That's what promotes healing and remodeling. Whereas a damaged tendon is more of a clump. It doesn't have that good sliding pattern. So we need to make sure that our exercises are varied, they're including some progressive loading, and that they match that patient's ability along the way. And again, the protocols within ChiroUp are going to have that diversity for you.
It's so interesting because I know you're giving a presentation for the Orthopedics Council on neurodynamics, but this is the same thing as spot welds, right? You know, is it really, it doesn't matter what tissue it is, you need it to move like it's supposed to move.
This may be more a glue spill in this case. Speaking of fun things to do, I have a quiz question for you here. Which Achilles tendon would be injured more frequently? The right, the left, are of equal injury?
Just being a basketball person when I was growing up, I would say my left, just because the cross crawl pattern and jumping and running, your left side's dominant.
That's a pretty good answer on the fly. I'm surprised. Sometimes it's hard to study for those, but you had no prep. There was a study that said 74% of people leap from their left foot. So you are correct. And I think that, this is something that came into mind for me that about the same time that I saw that article, this was a couple of years ago, I was following my wife around. She had this terrible habit called running, and it lasted for about 30 years. And so I'd go to some races with her. We were at the Houston Marathon, and I was running. We thought Houston will be nice. It's in January, beautiful weather. It was like 40 degrees and raining. And so there were puddles all over the place, which the only good part about that is you're not thinking about your heart and lungs. You're thinking about how to stay away from this water leaping over all these puddles. And about halfway through the race, I realized my left foot was soaked, that it was just drenched, and my right foot wasn't that wet. And I'm like, why is there water running out of my left shoe? And finally I realized that every time I jumped over one of these puddles, I jumped with my left foot. So my right foot lands at the edge of the puddle, because I can't jump far, and I'd splash up onto my left foot that was trailing just behind it. So it's not really unexpected that if most of us leap from our left foot, that our left foot is going to take most of that stress. I'm glad you asked that question because that's one of the things that is so interesting when you look at sports and golfing, and definitely the overhead athlete sport is how many problems they have on one side compared to the other one. And things to look at are patterns, because great providers are good pattern recognizers. And if you can find those things, you can help your patient not only get out of pain, but also find out what's causing it. So to round this out, as far as treatment of Achilles tendinopathy, you're going to find the eccentric exercises already in ChiroUp for the Achilles, the gastroc, the posterior tibialis. Don't forget about that posterior tibialis. That's one of the muscles we often forget because it's kind of hard to spell and type in your note. And then also get the helpers, those synergists. The flexor hallucis longus is also a good muscle to offload the Achilles tendon. And then finally, I'm on the bandwagon for Tom Michaud, his Toe Pro. It's a piece of foam essentially, but it holds your big toe in dorsiflexion, allows you to hit all these muscles. Kind of a neat little
gadget that I use for a lot of my patients that have stubborn, both plantar fasciitis and Achilles tendon, something to take a look at. However, that rounds out the clinical aspect of what we want to do. I kind of sprung this on Tim at the very end, but I want him to talk a little bit about EOS that we use for Chiro Up.
Yeah, so and not just for Chiro Up, that you're using it, next door at Premier Rehab as well, that EOS, the Entrepreneur's Operating System, this was based on a book from Gino Wickman, and it was just more of a system to teach small businesses how to operate kind of like franchises, to do the things that we need to do to scale. So we've implemented it next door at our clinic in Premier Rehab. It works very well. We used it in Chiro Up from the inception of Chiro Up, and I wish we'd have been able to use it at Premier from the inception of that many years ago. That EOS is something that helps just keep us on track, that the core of it is something called the VTO, or the Vision Traction Organizer. It's just a tool and a drill for you to sit down to develop your core values. What do you stand for? What kind of a culture do you want? What will you tolerate and what will you not tolerate? And then what's your mission? What's your purpose in life? And what are you and that team with the same core values going to accomplish? And looking long term, what are you going to do in 10 years? Not just what are you going to do today, because we all have those task lists, but what are we going to do in 10 years? And then what are you going to do in 3 years? And one of the tools that EOS advocates is a yearly planning meeting. I know a lot of you already do that, but it helps to provide some structure. But then it also breaks that structure down, saying, okay, here are your goals for the next year. Our goals at Chiro Up for the next year were pretty simple, that we wanted to have a highly secure system, that there were no data breaches, no cybersecurity attacks, and no compliance issues. And we've done that well from inception, but we know that healthcare is the biggest target for those types of attacks. So we've gone over the top to be cautious and protect that. Our number 2 goal was to have the top rated EHR by the end of the year. And we're not thinking that we're going to have the most utilized EHR by the end of the year, but we want the type rated. We survey our subscribers every year. How well do you like your EHR? And unfortunately they don't, and that's why we embarked in this process. And number 3 was to release that as quickly as possible. But by having that structure to say, okay, we need to make sure that we have number 1 and number 2 in place in the right order before we consider number 3, meant that our goal of getting that out by the end of summer means that now we're getting it out in the fall, a couple of months later, but we weren't going to sacrifice one of the other 2. So having that structure and defined in writing really helps to guide and help you make decisions that are going to be best for everybody involved. So one of the things that EOS does is quarterly ROCS meetings. So a quarterly ROCS meeting saying, here's your yearly goals. Now sit down for the quarter and tell us what you're going to accomplish this quarter. And what it does is it helps us determine what we're going to do on a daily basis. Where do we spend our time? That you've all seen the example of the jar of sand and rocks, that if you put the sand in first and then the medium rocks and then the large rocks, there's not space for the large rocks. Well, those are the tasks in our lives. There are some things that are just nonsense. We're going to check our social media feed. There are some things that are not super important. We're going to return this call, or we're going to mail this letter. And there are some things that are super important, that we're going to plan what we're going to accomplish next year. We're going to create a policy manual for our office. Those are the things that have to happen, and they have to go in the jar first. So quarterly meetings help us to define what are the 2 or 3 or 4 at the most things that you're going to get done this quarter. And then we have a weekly L10, and L10 is part of the EOS agenda as well. And again, all of this can be detailed in the book by Gino Wickman, Traction. This is not unique to us. It's something that we're using, and you're probably using pieces, but it's nice to get that polish. And the EOS L10 meeting says that every team member is going to have a KPI, key performance indicator. So every person in all of our companies have a number that you're going to be responsible for this. Maybe it's what were the number of recalls that were done? What was the patient, how many patients missed their appointment today? Or what were the collections, depending upon what your KPI is. In each L10 meeting, we go over the KPIs to say, what are the big numbers? What are the numbers that define our success or failure? What is our % improvement? Because that's our big one. And then we can also go over the ROC progress. Where do you stand with creating that policy manual or whatever you were trying to accomplish for your quarter? And then finally, we have the issues. And the issues are based on the first 2, that if there's a ROC that's not getting done, it's a team problem. How are we going to solve that? If there's a KPI that's not getting met, it's a team problem. So the issues is IDS. Identify the issue, discuss the issue as a team with the people who are trying to solve it with you. And number 3, solve it, which means there's going to be an action step. And those L10 meetings are timed, that they're not going to be wasted time. Each segment of that L10 meeting has a number of minutes. It really helps to keep things on track. And then they're rated, and that's why they're called L10, because you're shooting to get a 10, and that everybody had good use of that meeting.
So, I mean, I know that's a little bit different for our podcast than we normally talk about. However, this is one of the biggest things that help guide what we're doing the next day. So I think it's important for all of us to do, even as a chiropractor, and making sure all of our employees have that piece of information, help keep them on track. So if you haven't already, please make sure you follow the Mic'd Up Chiro podcast. We really appreciate that. Also, another little ask is I'd like to hear your biggest takeaway from the episode. Email me at brandon@chirop.com. Give me your takeaway or give me feedback on what you'd like to hear in the future. Otherwise, thanks for listening.
Hey, thanks for listening. To access more information, visit chiroup.com. You can sign up for a 14-day trial. Use referral code podcast15 for a special discount after your trial. Offer valid on new subscriptions only.